to the Compliance plus Ethics equals Integrity podcast, featuring BerryDunn healthcare professionals and expert guests discussing their insights into contemporary as well as perennial healthcare regulatory, revenue integrity, general compliance, and risk management topics. My name is Robyn Hoffmann. I'm a senior manager in BerryDunn's healthcare practice group. I am very honored to be joined by two of my colleagues, manager Natalie Laaman and a very new member of our team who we're welcoming today, senior healthcare coding and clinical documentation improvement consultant, Heather Bertolami. Welcome, Heather. Glad to have you here. The title of our podcast is Now It's Time to Think About Time-Based Billing for Behavioral Health Encounters. This podcast will be of particular interest to office-based behavioral health clinicians and to healthcare organizations that offer ambulatory behavioral health services, such as organizations as federally qualified health centers, FQHC lookalikes, rural health centers, certified community behavioral health clinics, and hospital outpatient departments. But first, before we get into our discussion, a quick disclaimer. The content we discuss in this podcast is based on our professional experience advising healthcare providers, facilities, and other organizations that engage BerryDunn for compliance and other services. While we may reference specific government programs, Medicare and Medicaid policies, and regulatory guidance, we do not speak for any government agency or contractor, nor do we have the authority to do so. Nothing in this podcast should be considered legal advice. Anyone seeking legal advice on the subjects we discuss should consult their own attorney. Now we're ready to get started. Natalie, you work with clients across the country who provide behavioral health services. We were talking recently about an uptick in some state Medicaid programs' scrutiny of billing by behavioral health providers. Can you give us a couple of examples of the types of issues that Medicaid auditors may focus in on?
Thanks, Robyn. We have seen Medicaid auditors focus on documentation of time for those time-based services, the presence of a complete and timely treatment plan, and the presence of the actual treatment note. There are a lot of behavioral health groups that have 1099 providers who keep their records separate. So it's important to be sure all your providers maintain their records appropriately, both for record completion, patient care, and of course, in case of an audit.
Thanks so much, Natalie. Heather, as you know, to expand access to behavioral health services in 2024, Medicare expanded the types of behavioral health clinicians, such as licensed marriage and family therapists and licensed professional counselors who can bill Medicare Part B. But Medicare and state Medicaid programs frequently differ in terms of which types of providers can serve as a billing provider. And we know that Medicaid rules vary from state to state, which adds even greater complexity for behavioral health providers to understand all of this. Are there any relevant modifiers that are based on provider types?
Great question, Robyn. State-run Medicaid programs are usually the only ones that require the licensed level modifiers. However, it's important to check with each insurance company for their requirements. These modifiers are based on the degree obtained by the provider. For example, a licensed clinical social worker would use modifier AJ. A master's level clinician would use the HO modifier, or a doctorate level or clinical psychologist would use modifier AH.
Thanks so much, Heather. I appreciate that. Natalie, can you remind our listeners about the CPT procedure codes that make up the series of psychotherapy codes that are time-based? In other words, which codes are these? And does documenting the duration of the encounter itself suffice?
The majority of psychotherapy codes are time-based, including individual therapy, group therapy, family therapy, and crisis codes. The CPT code ranges from 90832 to 90838, 90846 to 90847, 90853, and 90839 to 90840. It's important to read up on the CPT guidelines for the time requirements for each code level. There is a minimum threshold of time that needs to be met for each code in order to report to payers. And again, it's important to look at your payer guidelines. Some report the total duration, and then that's acceptable. Others require start and stop times.
Thank you, Natalie. Heather, based on your coding experience, what is your recommendation about documenting actual clock time versus the total duration of the encounter?
My recommendation is to build your electronic medical record templates with a start and stop time field that can automatically calculate the total time spent with the patient. This way, the provider can accurately capture their services. Since the build-out of templates varies by EMR, it's important to work with your EMR support team to see what is available. Some EMRs can drop the charge or CPT code for the service directly onto the claim. This is a great way to improve revenue integrity for the organization. In the absence of a template that can capture the start and stop times, the clinicians should specifically document this in their note, either by stating the start and stop times or the total time spent with the patient. As a reminder, check your state Medicaid programs, as some require the actual start and stop times. Another important reminder is to document the actual time spent with the patient instead of the appointment time, because we all know appointments rarely start on time.
So true. Any of us who have been patients can vouch for that one. So Natalie, while we're on the subject of time, are you seeing state Medicaid programs or commercial payers establishing specific requirements for the timeliness of authenticating a clinical encounter? In other words, what should a clinician do if there were an extenuating circumstance that delayed them from authenticating their encounter?
Requirements for timeliness of authenticating a clinical encounter really varies based on payer. Some require it within 24 hours, others are up to a week, and some are silent on the matter. The important point to keep in mind is that the encounter should be completely documented and signed prior to billing for the service. If there was a circumstance that delayed the provider from signing the encounter, that provider should document that reason in the record.
Thanks very much. So as we wrap up our conversation today, I would like to invite Natalie and Heather to offer our listeners your top 2 takeaways for behavioral health providers and for organizations that provide ambulatory behavioral health services. Natalie, if you wouldn't mind perhaps going first?
Sure. So at first, I'd recommend reviewing your payer guidelines and also the CPT guidelines to understand the requirements. And after that, I would perform an internal review to identify any gaps in documentation, specifically around time and treatment plans.
Excellent. And Heather, your thoughts on this?
Sure, I have 2 recommendations. Make sure you document your start and stop times and evaluate your patient's treatment plan to ensure it is in place and up to date.
Excellent. Thanks so much. I'd like to thank you both for sharing your insights today, Natalie and Heather. We've reached the conclusion of today's discussion about now it's time to think about time-based billing for behavioral health encounters. When visiting BerryDunn's website to access this podcast, our listeners may access links to several state Medicaid manuals from across the country. There's also a link to the Medicare Learning Network's Medicare and Mental Health Coverage Booklet from July 2024, which is a great resource. And we've provided a link as well to a recent Office of the Inspector General audit that focused on Medicare billing requirements for psychotherapy services. We thank you for listening to this episode of BerryDunn's Healthcare Insights Compliance plus Ethics equals Integrity podcast. We welcome listener questions and your feedback about the ideas we discussed in this episode, as well as suggestions for topics we should consider developing for future episodes. Many thanks.